Okay, welcome everybody. Tonight we got a great topic, and I've been looking forward to finding somebody to talk about this because I don't know about you guys, but I get a lot of foster kids that we struggle with bedwetting at night and potty training and just different things. So it's just nice to know that um, just what are some of the circumstances surrounding why a kid is bedwetting and things like that, and what can we do to help them, and what can we do for our sanity's sake. And so I met Kim Bloms, who's the CEO and pediatric therapist of Kids in Motion, and I kind of rattled off some topics that we've been looking for people to train on, and she said, oh yeah, we can do bladder and bowel movement. And so Kiah and Julie were kind enough. They're going to do our training tonight. And so I want to welcome them up to teach on this wonderful topic.
Okay. Okay. Thank you. Thank you for having us. We were just talking about how great this space is and what a great group this is. And so we're excited to be able to talk with you guys about potty training and bowel and bladder dysfunction and the treatment that we can provide. So a little bit about our clinic, Kids in Motion. We're located in Mandan. We just opened a brand new clinic, moved in there in April, and we have aquatic therapy. We offer bowel and bladder treatment, sensory integration. I mean, a lot of different things. And we have awesome therapists. We offer speech, OT, and PT for kids ages 0 to 21. So Julie and I are occupational therapists. And you can go to the next slide. Sorry. I'll have to remember to do that. So Julie and I are occupational therapists, and what we focus on are daily occupations. So that's any part of that routine. So getting up, getting dressed, eating breakfast, bathing, toileting, and then play, social skills, anything that's important and meaningful in your daily life. And so we work specifically with kids on the skills to help them be more independent in those areas of their daily life. Yeah. How big is your clinic?
So right now we have 2 speech therapists and we have 8 OTs.
Yep.
And then 2 physical therapists. So about how many was that? My math, 12 therapists.
Yeah, 12 therapists, and then we have 2 front office staff, and then Kim, and then a clinical director, and Renee.
Yeah.
She does a lot of things. So
there is Ashley Wagner Chiropractic. She's her own company, but she rents space from us 2 days a week. So Tuesdays and Thursdays, she does chiropractic care in our building as well. So I believe she is. I believe she is. I'm like 90% sure on that. I think she does. Yep.
she's really great to collaborate with too. She has a lot of knowledge and works really well with our therapists as well.
So some of the potty training basics. So we look at signs of readiness. Each kid's different. Some kids are going to be ready to start potty training more than others. So signs of readiness that we look for is recognizing when they're wet or messy. So that might be indicating like, hey, I need a diaper change, or they might indicate like, hey, I had a poop. They can assist with putting on or taking off clothing. So they might start pulling down pants. They might take off their diaper before you're quite ready to change them. They begin showing interest in sitting or using the toilet. They start going longer stretches without accidents. They're able to transfer on and off the toilet. They may or may not use a stool or steps, or even like just those smaller toddler toilets as well. Some factors that could impact potty training are social emotional deficits, intellectual or cognitive deficits, bowel and bladder dysfunction, which we're going to tie and talk about each of these more in depth, but sensory processing deficits and nutritional diet. Something I do want to note here is that daytime continence will precede nighttime continence. So kids will typically become daytime trained, and then around on average 10 months later, that's where we'll see more of that nighttime continence and training happen. So don't panic if they're daytime trained, but nighttime's taking a little bit longer.
So just to dive in on each of these factors, the social emotional piece, so looking for those behaviors, whether it's triggered by using the bathroom or having a soiled or messy diaper. Fear of the toilet. Some kids struggle with like the noise, the environment, the smells, and we'll kind of dive into that sensory piece as well. Or if they've had trauma or other adverse experiences that could be impacting their ability or want to use the bathroom. Some intellectual factors include being able to communicate their wants and needs. So maybe they understand that they're messy or wet, but instead of being able to tell you that in a way that's functional, they might start crying, having a meltdown. And sometimes it's difficult when you see that. It's hard to know exactly what they're trying to communicate in that moment. And then ability to sequence steps of using the bathroom. So going in, being able to undress, sequence those tasks of wiping and then washing their hands, and all of those pieces too can also impact that toileting routine.
Okay, so bowel and bladder dysfunction. So we might see pelvic floor weakness and poor endurance. We might see constipation, poor diaphragmatic breathing, decreased core strength, daytime dryness versus nighttime. So these might all indicate bowel and bladder dysfunction. So we might have some bowel incontinence or bladder incontinence. One thing I will like to show, Kiah, I'll have you hold this. All right. So I brought a fun diagram. This was fun walking through the building with holding a pelvis, but so this is the pelvis. And so your bladder is actually a muscle. So like your heart, it works without you thinking. The bladder is also a smooth muscle. So we also have pelvic floor muscles that work by contracting and relaxing. So we do it without thinking. However, some kids, when we're seeing bowel and bladder dysfunction, that becomes voluntary. So they're having trouble relaxing, or they're contracting at the wrong time. And so what we can look at is pelvic floor and strengthening that. But what I want to show you, so this is our pelvis. So you have your pubic bone, you have your hip bones, your tailbones here in the back, but these red muscles here, that's your pelvic floor. So it's the floor of your pelvis. Basically, it acts like a sling. And so those muscles are actually contracting and relaxing. So it contracts when you're like, oh, I have to go to the bathroom, not quite there yet. And it relaxes at the appropriate time. We oftentimes don't have to think about it. Some of our kiddos do though, and that's where we see a struggle. So what I'm going to show you now, this balloon is going to be your bladder, with the end being your urethra where the pee comes out. So what I'm going to show you are kidneys, filter our waste and everything like into our urine, and then the urine comes out our urethra. But I'm going to kind of show you what would happen if it doesn't contract when it's supposed to. Okay, so this is our bladder. It fills until it sends a signal to our body that, oh, we have to empty. So it sits here and then it'll relax and empty. However, like at the beginning, how I didn't have a good contraction and it was kind of just leaking out, sometimes that happens with our kiddos. The other thing too, I'm going to fill it up again. Yep. Okay, so this is our bladder again. It sits here. If we're constipated, our bowels can actually push against our bladder and actually cause it to leak out, our bladder leak out. So that's something else we can look into. That, are we having pelvic floor dysfunction? Is it a potty training issue, or is it constipation causing some leaks?
You ready? Yep. Okay. We can go on to the next slide too. Thank you. So I'm going to touch on some of those sensory needs, or that sensory system. So everyone has different sensory needs, right? So some people enjoy listening to music while they work. Other people need silence, right? So kids, sometimes their sensory system can be off to the point where it's impacting their ability to participate in their daily activities. So we're looking at potty training, the auditory components, or being able to hear some of the sounds like of automatic flushing, turning the sink on and off, the lights, if they're buzzing. Some kids are very sensitive to that sound and can hear those things. We might not be able to hear it, but they can, and that can throw them off too. Tactile or touch. So the cold toilet seat, the texture of the floor, the texture of the toilet paper. It could be the texture of their diapers or the underwear that they're wearing. Visual sight, so even just seeing the poop and pee that they're seeing in the toilet could throw them off. Other parts of the bathroom, the lights are too bright. They might need the lights off. Gustatory, so taste, they might be clenching their jaw. So some kids, even just that, and this kind of goes with a lot of different things with like that motor planning and stuff. Some kids can have overflow in their mouth when they're using other parts of their body. So that's where you might see some of that straining, and that can be painful or otherwise overwhelming for them. That olfactory, the smell of using the bathroom. I mean, that could be air fresheners. It could be what they're releasing from their body. I mean, there's a lot of things that go into that as well. That vestibular piece. So that has to do with that balance. And so kids who struggle with that vestibular system could feel unsteady or unbalanced when they're sitting on the toilet seat, especially because it's not a flat surface. So there are things that we can do to support all of these systems, but one of those things is even just adding a stool for them to put their feet on. So there's different interventions we can do to support them that way. Proprioceptive, and that's that sensory system that tells us when our body is in movement and where our body is at. So sensing those sensations in our joints and in our muscles. So part of that is even with those muscle contractions, like being able to sense where their body is. And that kind of goes into our interoception piece, understanding their body systems, the temperature, we're feeling hot or cold, if we're feeling full or hungry, when or when not we need to go to the bathroom. So those are all those sensory systems that we as OTs specifically work on and target to kind of help kids be more aware of their own body and be more independent in those daily routines.
Okay, so nutritional diet, it impacts our bowel and bladder. Most bladders are happiest with proper hydration and a healthy diet. So hydration, as a general rule, the amount you drink is based on your body weight. So if a kiddo's 30 pounds, we'd want about like 13 ounces. Each kiddo might be a little different. So I always consult with your pediatrician as well. But signs that they might not be drinking enough would be dark, yellow, or smelly urine, difficulty having a bowel movement. And you can tell because they're straining or pushing really hard, or they're not having regular bowel movements. So having 3 or less bowel movements in a week. Typically, we like to see 1 a day or 1 every other day. So water is always the best beverage of choice, but some others that are motivating for kids are those grape and apple juice, apple juices. They're less irritating to the bladder. Always check though for high sugar too. Like some of the juices are full of sugar, but so then fiber. Fiber is a big part of our diet. There's 2 types of fiber. There's soluble and insoluble. And they both have different jobs, but they're important for regular bowel movement. So soluble is the type of fiber that dissolves in water. It's most commonly used in fiber supplements. So there's several health benefits with consumption of soluble fiber, but the highlight is it's most relative to bowel and bladder. It assists with the regulation of bowel movements. So then insoluble fiber, that's the fiber that does not dissolve in water. And this type of fiber also plays a role to help with constipation or irregular bowel movements. Since it does not mix with water, it doesn't absorb and can help also with diarrhea too. And then we have bladder irritants. So some foods are bladder irritants, so they irritate the bladder, cause more accidents. So some might be like artificial sweeteners, caffeinated beverages, carbonated beverages, milk, chocolate, citrus fruits and juices, such as oranges and grapefruits, spicy foods, tomato-based products, and any foods with red or blue dye in them. So we're not saying don't eliminate them, but this just could be a factor that's playing a part in increased accidents. And then some bladder happy foods would be like low acid fruits, pears, apricots, papaya, watermelon, and then rice or almond milk. So the highlight of this is to note, like, we're not expecting like these massive nutritional changes. However, it's important to know that hydration and nutrition do impact our bladder and bowel movements. So.
And they don't necessarily affect everyone in the same way either. And that's something that when we talk about when we have a kid come in, we're doing a bladder log and having them tell us what they're eating in a day, how often they're going to the bathroom, if they're wetting at night. So we look at all of that to see what is impacting, what can we change, and see if that works. I mean, everyone is a little bit different with those foods, but they can definitely help with making some of those diet changes. So we're going to go through a couple of the different parts of that bowel and bladder dysfunction and kind of hone in on some of those things. So daytime wetting, so that's involuntary urination. So that would be children who just have unintentional leakage during the waking hours, right? So that could be we try to stay away from saying accidents, right? Because we want them to know that they can gain control of their bladder. And so we'll say leaks. So they have bladder leaks throughout the day. Frequent leaks would be if they're having multiple leaks, even if they were previously potty trained. So Julie kind of talked about that with constipation, sometimes that can cause the bladder leak out. So if they're having, even if it's a small amount, drops of leakage, that's still a leak. And something in there is not they're not able to hold that urine in. Incomplete emptying of the bladder. So if they're going to the bathroom and not able to fully relax, their bladder is not going to be able to fully empty. And so then they're leaving that in there. And that's one of the issues with that, is if they're not fully emptying their bladder, it's not giving their bladder the correct input to be able to know how much it can hold and how much to let out. That makes sense. So that's part of the relaxing and contracting those pelvic floor muscles as well. And then increased urinary urgency or frequency. So having to go to the bathroom more frequently in order to manage those bladder. Yeah. And we are going to leave some time at the end for questions so that you guys, because I know with this topic too, we just expect that there are going to be a lot of questions. So feel free to ask us at the end too. You can go.
So some causes of daytime wetting is overactive bladder. So a bladder that contracts too frequently or involuntary can lead to increased urgency and daytime wetting. Constipation, kind of as we talked about a little bit, it can put pressure on the bladder, affecting its function and leading to urinary issues or leaks. UTIs. So this is why if a kiddo is having increased frequency or pain, always go to their pediatrician, because that's a sign for a UTI. But infections in the urinary tract can cause symptoms such as increased urgency and frequency of urination. Psychological or emotional factors, so stress, anxiety, changes in the child's life can contribute to daytime wetting. So I'm sure you guys see a lot of this. There's a lot of changes in routine, so that's something to keep in mind too. Structural or neurological issues. So there could be some structural abnormalities or neurological conditions that may be playing a role in daytime wetting.
All right, so when we're looking at this bladder dysfunction or bowel and bladder dysfunction, there's different ways that we can help manage this. And part of that is consulting with the healthcare provider. So that's really that first step, talking to your healthcare provider to say, this is what's happening. We've tried this, this, and this. I feel like there's something else. And then even requesting a referral for an evaluation for bowel and bladder treatment. Addressing the medical issues. So like Julie said, UTIs, if there is any underlying condition or infection that could be impacting that, we want to make sure that that's taken care of first, because then we can really understand if there is a problem or if there is a difficulty versus not. So the doctor is going to be able to help with that. Looking at the hydration, making sure they're taking in enough water throughout the day. I know sometimes kids are so busy, it's hard for them to stop and drink water, and they sometimes forget. So just always having a water bottle available for them is the best way to encourage them to drink that. And at school, if they can have it on their desk, take frequent breaks to go to the water fountain every time they pass it. It's a good way to kind of add that in.
Can I add something?
Yeah.
So if your kiddos are like mine, they don't want to stop and drink water, even if you have a water bottle readily available. Stickers are a great reinforcement. We're going to drink to Marshall from Paw Patrol by, this time, then lower on the water bottle. Okay, now we're going to drink to Chase. So sometimes just that visual and making it motivating for them is a great way for them to also add in that hydration piece.
And then that kind of goes along with that positive reinforcement, right? So adding in a reward system, helping them gain that like motivation to want to use the bathroom and want to go potty. And so that could be through a potty chart, whether you use stickers, they get a small reward each time they go to the bathroom. I mean, I feel like every kid is different in how they learn. And again, it kind of goes back to like wanting them to take control of their body, right? Them being able to use that. And so I think giving them that positive reinforcement really can empower them and make them feel more independent as well.
Okay, so now we're going to move on to nighttime wetting. So signs and symptoms would be bedwetting. So the most obvious sign is the occurrence of involuntary bedwetting during the night. The child may wet the bed regularly or intermittently. Parents or caregiver may notice wet sheets, blankets, and pajamas in the morning. Typically, we see it, it's common in the younger years, especially when you're in the process of toilet training or the kiddo has just become daytime trained. It's considered more of a concern if it persists beyond the age of 5 or 6, especially if the child has achieved consistent dryness before and they've been dry consistently throughout the day for about 10 months. Frequency of occurrence. Nighttime wetting may occur every night or sporadically, depending on the child. Children experience nighttime wetting. They might feel embarrassed, frustrated, or anxious about the issue. They may avoid sleepovers or express concerns about the condition. Daytime. Sorry, I have to flip my page. So daytime symptoms, they might have increased thirst, frequent urination, or discomfort during urination.
So some causes of nighttime wetting could be delayed development. So some children just may take longer to develop the ability to control their bladder at night. And like we said, it can take that 10 months, which is quite a bit of time from that daytime continence. Genetic factors. So bedwetting tends to run in families, so that the child is more likely to experience it if one or both parents had difficulties with bedwetting. Hormonal factors. So the production of an antidiuretic hormone that helps concentrate the urine, but may not yet fully mature in some children. So sometimes that can lead to that bedtime wetting too. The bladder capacity. So if they have a smaller bladder, they aren't able to hold as much and they have difficulty holding it at night. So thinking back to Julie's balloon, if it's only blowing up a little bit, if you think about at night, they're collecting more, they're waiting longer, they might not be able to hold that in. Constipation can have an impact on that as well. So if they're constipated and the bowels are putting pressure on the bladder, that can cause it to leak out. UTIs, again, something to think about too, and make sure that there's nothing there. And then just those psychological or emotional factors, whether there'd be stress, a big change, life change, difficulties at school, those can also be contributing factors to that nighttime wetting as well.
Okay, so with nighttime wetting, there's the primary nocturnal enuresis or nighttime wetting. So this is bedwetting that occurs when the child has never actually achieved consistent nighttime control. And it's commonly related to just developmental factors or some of the issues that we talked about earlier, or they're still kind of going through that potty training phase. And then there's what's called secondary nocturnal enuresis or secondary nighttime wetting. And that happens with a kiddo who has previously had consistent dryness during the night, but then has started bedwetting again. So this can be triggered by various factors, including stress, changes in routine, and underlying medical conditions. So now we move on to what can we do about it? So some management would be looking at that diet again, avoiding bladder irritants, especially before bed. And then avoid fluids before bedtime and hydrate. So that kind of contradicts each other. But what we're looking at is they're hydrating enough during the day that about an hour before bed, we can have them avoid fluids. So we still want to focus on that hydration, just not chugging our whole water bottle right before we go to bed. Emptying the bladder regularly, avoiding constipation and straining, doing like different exercises, getting movement in. And then there are alternative strategies like bed alarms. That's not always our first go-to, but there are options out there for that.
And I feel like too, just every kid is different. And so like we've kind of been talking about, there's a lot of different strategies that we can try and every kid responds differently to the different things. So I feel like bed alarms is a good example of that. Like some kids do really great on those. Some kids don't even notice that they go off because they're sleeping so hard. So Constipation. So constipation is identified as no bowel movements with over 3 days, right? So we want to make sure that we're watching our kids to see where they're at. So infrequent bowel movements, while the frequency can vary, if your child has significantly fewer bowel movements than usual, that may suggest constipation. So even if your kid is going 1 or 2 times a day, 1 every other day, and then all of a sudden it's been a few days, they could be constipated. Hard stools, so are often dry, hard, or difficult to pass. They consistently appear firm or pellet-like, then it could be a sign of constipation. If they're straining, so if you see they're visibly straining, their face is getting red, they're looking like they're working hard or in pain. Abdominal discomfort or pain, and this could be while they're going to the bathroom, this could also be throughout the day. This could be impacting them more often than just when they're using the bathroom. Stool withholding, so kids who have a fear of pooping on the potty, they might hold, and that can also cause that pain and then increase the fear, knowing that it could hurt. Changes in behavior can also be associated with constipation. I heard something once that said the gut is like the second brain. Like there is just so many nerves in there, and it's a huge part of where we feel those emotions. And so when your gut is not feeling good, it can really affect how your day is going. And so kids can really portray that. And sometimes their behavior is off. Sometimes they're more emotional. So they're struggling to pay attention. They might not be eating as much. And so I think those behavioral changes are really important to watch for, because that could be a sign of that constipation as well. Anal fissures or tears. So so just as far as straining during bowel moves, that can cause small tears around the anus, leading to pain or discomfort as well. You might notice blood on the toilet paper or in their stool. Bowel smelling gas. So they're passing more gas. It smells bad. And you probably know they could be constipated. And then streaking in their underwear. So one thing with this to think about is if they're constipated, I feel like sometimes parents don't realize, because they're getting streaking in their underwear and they're not realizing that it actually can be the looser stool can pass past the stool that's stuck because it's taking up so much space, but then so they can still be constipated even if they're having a bowel movement per se every day, but if it's loose, it's able to get by.
Or we'll often commonly hear, but they're having diarrhea. And so kind of what Kiah, as she was saying, that our stool can build up. It has to get out somehow. And that's where the looser stool will actually get around the hard stool. And so you'll see streaking in underwear, diarrhea, or poop leaks.
Mm-hmm. And the child might not even recognize that that's happening because they're so backed up and their bowel is so tight and full that they might not realize that they're leaking. And that can be very emotional for the child. It can be very emotional for the parent. It can be frustrating. So that's another thing to think about too.
So causes of constipation, dietary factors, lack of fiber in the diet, inadequate fluid intake, or a diet that is high in processed foods can all contribute to constipation. Lack of physical activity, so it can slow down the bowel movements and contribute to that constipation. Emotional factors, stress, anxiety, or changes in routine can impact a child's digestive system and lead to constipation. And also the emotional factor, as Kiah indicated before, too, if they are constipated and they had a painful poop, they're likely to be fearful of using the toilet in the future. And so they withhold, and then that just increases the constipation. If they have toilet training issues, so they might just resist using the toilet for pee or poop. So then that's going to cause us to get a little backed up too. And then there's different medical conditions that just might slow down our bowel motility. And also certain medications also can play a part in that as well.
All right, so we're going to talk a little bit about the management, similar to the bladder dysfunction management, but also looking at those diet modifications. So if you remember the brat diet, for kids with diarrhea, the bananas, rice, applesauce, toast can help firm up the stool and help if they are on diarrhea, but they can also be constipating. So if you think about a kid who's already constipated and these are their primary foods in their diet, it's not going to help them be able to pass that. So that includes bananas, rice, applesauce, toast, peanut butter, cheese, dairy, processed foods, and red meat. The bowel needs fluid to keep things moving and hydrated. So they should be drinking their at least half their body weight in water per day to kind of help move those things along. Get moving. So activity is really great to get things moving. Having kids go to the park, play outside in the winter, building obstacle courses in your house. Getting that exercise can really get everything moving through. Sitting with the feet elevated. So using a little stool if we ideally want their feet on a steady surface. If their feet are hanging, it's really hard to work on contracting those muscles to help release that poop. And so having their feet up either on a squatty potty or a little stool can be really helpful as well. And then teaching them to relax. Don't hold it. It's hard for some kids to learn that because especially if they have had a painful bowel movement before, but just trying to relax and use that diaphragmatic breathing. We talk about that a little bit too, just to help them with that relaxation, but also moving those through. And then trying to poop after meals. So sometimes it helps even to do like a warm drink afterwards to help get things moving, and having them do a toilet sit after a meal can help too.
All right, so choose your poo. I have a fun job. I get to talk about poop and pee every day and show this visual, but this is called the Bristol stool chart. And so what it does, it lists the different types of stool and it acts as a visual. So type 1 and type 2. So type 1 is what we call, it looks like rabbit turds. Type 1 or type 2 looks like a bunch of grapes. So these kiddos are constipated. Now we can't diagnose constipation, but we can look at that and be like, yeah, they're backed up, like they're having constipation like symptoms. Type 3 looks like corn on the cob. It's a sausage, but there's little cracks. Type 4 looks like a sausage, so it's smooth, it looks like a snake, small and soft. We like kids to be at a type 4. Type 3 is okay, but typically we like that type 4. Type 5, chicken nuggets. Type 6, porridge, and then type 7 is gravy. So type 6 and 7 is where you're moving more into that diarrhea. So we use that tool. Oftentimes for parents when they are in caregivers, when they come in, we'll have them track what their kid's poop looks like. And depending on the age of the kiddo, we have the kid help as well, just because autonomy of their body and everything too. And they can help take ownership and responsibility, especially to some kiddos, they're in school every day. Caregivers don't have that time and they're not with the kiddo 24/7 to track that. So school age kids, if it's appropriate, we can have them help track it too.
And it's similar to like when we're talking about hydration, having kids look at the color of their pee, wanting to get it more clear versus that dark yellow color. This gives them a visual of, okay, this is what's happening. Maybe I need to do more of this. And it just kind of gives them that autonomy then to be able to make those healthy choices and to help them be more in control of their body too. So what have you learned so far? Is there any, we're gonna go over some of the like red flags or reasons to refer, but we kind of wanted to take a quick break. If there's any like fun comments, otherwise we can just keep moving too and leave it for questions at the end. Yeah. Yeah.
Is it okay to work Miralax into a routine with kids?
That's a great
Good question.
Uh,
Okay. So, oh, sorry if you want
I
to
was say
too.
my asterisk is always refer to your pediatrician. As therapists, we can't technically prescribe, but Miralax is a good way to get that stool burden out and get that stool out and moving. We just don't want kiddos to rely on it.
And that's kind of what I was going to say too. I feel like it's when a kiddo comes in and they are backed up and they need something, sometimes the doctor will recommend using Miralax for a while just to get things moving and help them have more regular bowel movements. And then our job is to help support them in building those healthy habits, building up that pelvic floor strength, so that they can wean off of the Miralax. And so the goal isn't to use that forever, but it's definitely okay. And there are times where it's necessary and the doctor or their pediatrician is the one that's going to decide that and recommend that. Good question.
Yeah, that was a great question.
Anyone else? Yeah. Yeah.
I keep forgetting that.
I do.
That's
forget.
okay. I have a question, the whole reason I came here is to ask this question. So, I have a 10-year-old, he's almost 11. He has significant bowel issues. So like I noticed it by his underwear because it was like, it wasn't streaks. It was like looking like he was like pooping his underwear. So anyhow, got to the doctor. He's severely constipated. He goes on a laxative, but he's still not pooping. And he's like, my stomach hurts. I'm like, we'll go to the bathroom. But that's not the problem, even though I go over it all the time, but the x-rays say it is. So go back to the doctor. He's still extremely constipated. That laxative didn't help. They put him on a second laxative. So now he's on 2 laxatives. And he is still extremely constipated and not pooping or accepting that that's why his stomach hurts. So it's like, what do you do? He's almost 11. He also has bedwetting every night. And I thought, oh, maybe that's from the constipation because it gets so bad at like, he wears good nights to bed, but he still leaks through those consistently too. So, I don't know what else to do. Like we keep going to the doctor.
I think I'm glad that you shared that because I feel like there are parents that struggle with that too. And it's hard when you've gone to the doctor and you've tried things. And so I think that's where we can kind of support in that, like, because there could be other factors too, right? That are contributing to that constipation that maybe the laxatives are not quite helping enough. And so we can look at more of that whole body. Like I like working with the doctor because they have that medical piece and then we have the body piece, right? Do you have anything to add on that as far as?
Yeah, especially at his age. Like,
Mhm.
is he cognitively like age appropriate? Yeah. So at his age, since he has that cognitive understanding, having him learn about the body and that like that, hey, this is our digestive system. Like this is what happens the second food enters our mouth. This is where, and kind of like that scientific piece. I mean, age appropriate, of course. That scientific piece, and then talking about our digestive system and how it comes out, but then also kind of educating him on what's happening and what the doctor's saying, and like, and then how can like, how can therapy help, or here's what we're going to do at home to help, and the purpose behind it.
Well, and if they've done x-rays or anything, you can even show him the x-rays and say,
Yeah.
okay. Yeah. Yeah. Mhm.
And he might not be feeling it. Sometimes what happens with constipation is it stretches and stretches and stretches and they lose that sensation, or it's just very diminished. And then also that sensory processing piece that Kiah went over, that interoception, our internal awareness, he might have difficulties recognizing like, oh, here's what I'm feeling. That means I have to go to the bathroom.
Mhm.
I would recommend starting bowel and bladder therapy in your case. That's not always my first jump. Like there are a lot of things you can try at home and talking to your doctor. The steps you've taken so far, and it sounds like you've been very proactive. I would do bowel and bladder therapy at this point. Do you have any?
No, that's what I was going to recommend too. And we're actually going to go in on like the specific treatment strategies that we can provide. So you'll get a little bit more information on that. But I agree. I feel like you've taken that first step of taking that medical intervention. And then now what we can do is we can support and like identifying or looking at that sensory system, education, looking at the pelvic floor muscles, and we can actually like specifically test those muscles and see if they're contracting and relaxing. They're so small, but we have a really cool machine that does it and kids love it. And so it can be really beneficial for that too. So yeah, I think it's great that you've been able to advocate for him and get that medical care, but that would be my next recommendation for that step. Yeah.
Mm-hmm. Yeah.
Yeah, for sure. Yeah, thank you for sharing and thank you for asking. So maybe we should go on to the next slide, and then we'll leave some more time for next question. So we can kind of go into what are some of the things to look for and what are some things that we can do to help.
Yep. So when should I be concerned? So again, like I mentioned, it's not always my first step to be like, oh, you need bowel and bladder therapy, you know? But there are red flags where it's time to refer to OT or PT that's trained in bowel and bladder dysfunction. So pain or discomfort, if it's persistent in that abdominal or pelvic area, and if it's associated also with bowel movements or urination. Changes in appetite or weight loss. A lot of our kiddos that are constipated will often be picky eaters. They'll have a limited diet because they are so full that they just don't want to eat. Or they have a limited diet, so then that plays a part in that constipation piece. Or if you see developmental regression, so they were toilet trained and now we've seen a regression, or they weren't having nighttime accidents and now they are. If you see chronic constipation, blood and stool, fecal incontinence, changes in bowel habits. Yeah, recurrent UTIs. So UTIs, I always refer to the primary physician, but in my mind, if a kiddo is getting recurrent UTIs, I want to dive in further because that could be a pelvic floor dysfunction, or a sensory piece, or, not recognizing that they're wet or have to go. And then if they're not fully emptying, so these are the kiddos that they go to the bathroom, they don't fully empty, they come out, they're playing, and then they have an accident, or within a few minutes, oh, I got to go to the bathroom again. So that's a sign that they're not fully emptying.
So some things that we can offer at the clinic is a skilled evaluation. So we take that holistic approach. We're going to ask you all the questions about their diet, about their hydration. What have you tried so far? What do your bathroom routines look like? And as OTs, we're going to look at that sensory system. We're going to look at the strength of the muscles, all that kind of stuff. So we're going to look at a lot of different things. The SEMG is this tool that we have that I talked about as far as getting like a sense of how those muscles are working. So like I said, those pelvic floor muscles are so small. And so what we do with the SEMG, we use electrodes to measure the contraction and relaxation of the muscles. And so there's no sensation, we're not forcing that contraction, we're just measuring it. So those sensors give us that feedback on a screen. So the kids can actually see when they're contracting their muscles and when they're relaxing. It also helps us to be able to see, are they always contracted? Are they unable to fully relax? And so what it looks like is we kind of have a bar on the screen and we'll see them if they're contracting, the piece is moving up. If they're relaxing, it's going down. And we actually have games that the kids can play. And so it might be a butterfly trying to catch the gems. And so they have to contract their muscles to get the gems up here and then relax to get the ones down here. And so we're able to track that and then help the kids get that visual feedback of what they're doing so that they can better coordinate that contraction and relaxation as well.
Yeah. So with the SEMG, one thing to note, nothing is internal. So these electrodes, the only thing it does is sense their contraction. So like the kid's not going to feel anything other than there's like a little sticker placed around their privates. How we do that process is the parent or caregiver are the ones who put it on. We have a diagram and we educate where to place it. We step out of the room. The kiddo's fully covered when we come back in. The only way that we would put it on is if the caregiver is not comfortable, or the parent, if they're like, hey, I don't think I'm getting it on them in the right place. But then we get the parents' permission, caregiver's permission, and we have something signed also just to protect the kiddo and ourselves. The other thing too is autonomy is a really big one for this. And so we educate the kiddo on safety. So why we're doing this, it has to be okay with caregiver and you. It's not okay for anyone to look or touch unless it's a medical provider who's trained in this and specifically addressing this issue. So safety is a big part of this too. So I just like to highlight that as well.
And using the anatomical names for the body parts as well, because that's really important for kids to understand and just be protective of their body too. So we talk about that, and we never push it, right? Like we wait till the kids are comfortable. Some kids are ready to go and they're comfortable with their parent helping them with that. And if they're not right away, then we wait a few sessions. We don't need to do it right away either. Once they see it and get going, most of the time they're a little bit more comfortable, but it can be a scary experience right away. So we try to make it as comfortable for them as possible. Other pelvic floor strengthening exercises, there's a lot of things that we can do outside of the SCMG. So the SCMG works like primarily on those pelvic floor muscles specifically so they can see that, but we can also do some core strengthening. We can do some lower extremity strengthening and hone in on those pelvic floor muscles as with the whole body movement. So bridges, bird dog exercises, lunges, there's a lot of fun things we can do, and we can make it fun for them as well. I like to do the exercises with them because then it motivates them and I get a workout in, it's fun. We have a good time. And then Mary Massery, so we took her training a couple of years ago, and I always forget what the name of the training we did, but it used to be called If You Can't Breathe, You Can't Function. And that's what sticks with me because it is so great to just see how being able to breathe in a functional way can just help with so many different things. And that's postural control. It's being able to maintain that bowel and bladder continence and consistency. So we'll use some of that diaphragmatic breathing techniques to help strengthen the diaphragm and help coordinate those breaths to help with that contraction and relaxation of those pelvic floor muscles as well. And then other skilled interventions. So in OT, we'll look at that self-regulation piece, whether that be sensory processing and that emotional regulation. Graded exposure. So we have a good example of this is we have a little toilet seat that's not meant to be used to go on. We just can take it around the clinic so kids can practice sitting on it. And then we slowly work our way into the bathroom. And that's a way we can grade that exposure to make them more comfortable with being in the bathroom. Interoception, so educating them on their body and being able to sense those sensations. And that's not just going straight to whether you're messy or wet. It's looking at temperature, the feeling of my hands when I close them versus when I open them, that kind of stuff too. Executive functioning. So that executive functioning is an umbrella term for all those skills that have to do with being able to with that self-management. So being able to work through steps, follow directions, sequence the parts of the routine to go to the bathroom, taking initiative to go to the bathroom, that kind of thing. And then feeding therapy. So looking at diet. So Julie and I are both trained in SOS feeding, which is a sensory-based approach to help kids explore foods in a way that feels safe and comfortable for them to help expand their diet. With diet, it's hard. Sometimes it's the diet that's contributing to the constipation. Sometimes it's the constipation that's contributing to the diet. So Julie kind of mentioned that before, but it's definitely something that we can work on in a way that's fun and feels comfortable for them.
So family focus and collaboration, the benefits of a team approach. So at Kids in Motion with our Bowel and Bladder program, we truly do use a team approach where you guys are the primary role in this team. And so we take that into account. And the kiddo, and then also working with our pediatrician as Bowel and Bladder. A lot of times we're working with talking about are they on Miralax? If not, what's an alternative, or, we kind of work with the pediatrician to figure that out, but then also looking at the whole body. So individualized plan of care and home exercise program. So as Kiah mentioned, we look at the whole body as there's so many factors that can be playing a part in bowel and bladder dysfunction, and then correct therapy dosing. So we're not just going to have every kiddo that comes in, yep, I'm going to see you for 1 day a week for an hour. We're going to truly figure out what that kiddo needs, and then we always adjust it from there as well.
And we do have a physical therapist that's also trained in bowel and bladder treatment. And so when you make that phone call, our front desk is pretty good about doing a screen of okay, is this PT related or is this OT related? Because there is a little bit of a difference there as far as what we can address as far as that sensory processing piece. But then there's also times where maybe there's multiple things we need to work on, and we can work together as a team between PT and OT to address that toileting routine together as well.
One other thing to note is we do offer free screens. So if you're not sure, hey, my kiddo needs bowel and bladder therapy, you can always call and set up a screen. It gives us time to talk, and it's completely free. We set aside a half hour where we can talk and kind of gauge, okay, can we handle this at home with these interventions and these ideas, or do we need to get started with bowel and bladder therapy? And from there, we can set you up with an eval, or just give us a call. We'll set aside time for you to
We've done that
questions
too, where someone calls in and has a question, and one of us will chat with you and talk about what to recommend.
So questions.
Oh, awesome.
Okay, her question was kind of similar to our earlier one. What do you do when they are consistently having issues when they are in school and they don't even recognize the smell, or other kids see or smell that bowel incontinence, but they're not really recognizing this? I actually had this same situation with my very first foster child, and so I'm interested in your answers.
So kind of going back to that sensory system, that interoception piece one is when they're going to the bathroom, right? But then also that tactile, maybe they're not noticing that mess, and then the smell, right? So there's a lot of sensory factors that can go into that. So that's something that we would look at and want to talk about too. And then I think just it's hard to know based off of this, but looking at constipation again, just different hydration, different factors to kind of see, but
I would also look at routine or even the emotional side of it too. Like, is it something where they don't feel confident enough to pause and ask the teacher that they have to go to the bathroom? Is it the bathroom set up at school? Are they just not taking the time to go? So there could be a lot of factors going on with that too. Yep.
I've been writing down questions because I feel like I live this world with most of my placements. So maybe, is there anything you can do to work with schools on this issue? And thinking about what you're just talking about. So this kiddo that I had, the school would not help when there were accidents. So they would send this child into the bathroom, into the stall alone, which I understand, but they would do this to take off their pants that were full of poop, and then poop would be everywhere. And then they'd throw it in a bag and send it home. And they would leak 7 to 15 times a day. So like, how can we work with schools to try to find some sanity for everyone?
I'm glad you brought that up, because I actually meant to add that on to that last question too, is I would try to work with the school. Now, HIPAA, our laws is I can't just call up the kiddo school and say, hey, I'm working with so-and-so. Here's what I think. We have to go through the legality of getting the guardian, caregiver, parent to sign a release of information. And from there, we can work with the school. But that's where we can provide and advocate our medical background and say, hey, here's what we're seeing. Here's what's going on. Here's what we would recommend. Now, schools too, their hands are tied sometimes with the amount of kiddos in their classroom. If the kiddo is on an IEP or a 504, or if there's not a plan in place. But I have worked with some schools, if there's a IEP or 504 in place, to get kind of a toileting routine set up in that school. And depending on the age of the kiddo and the cognition of the kiddo, having them take initiative too. And so educating them on, well, here's the importance, here's how we're going to work through that hygiene piece of, if we had an accident, here are the steps we take. And so that's where occupational therapy can play a part into that executive functioning that Kiah was describing earlier, with understanding, okay, the sensory piece, I had an accident. Now that planning and sequencing of, here's the steps that I have to do. Yep.
And part of that too is even just them understanding like the appropriate tools to use. How do I go about this? When do I need to ask for help? That kind of stuff too, helping them pack a bag so that they're ready if that does happen. And then, yeah, just, I think working with the school too and helping them understand. I think that's where sometimes that disconnect can happen, is if they're not aware of the source of the problem too.
Yep. And some guardians and some kiddos don't really want us talking to the school just for privacy reasons, and like, because it can be a sensitive topic. But one thing I would say that caregivers can advocate for is, can we, if the kiddo's embarrassed, can we discreetly provide like a bag where they go in and change? Can the teacher discreetly be like, hey, okay, change, here are the steps? So that's one place I would start, is coming up with a plan with teacher. Yeah.
So Leslie asked if there's been any pushback from the schools. I personally haven't. I feel like most of the time when I'm working with schools, they're just happy to have some extra support and some education on it. So I have not. And sometimes I feel like it's a process for parents to get the supports that they need, but that's where I'll help them and educate them on things that they can do, things that they can ask for, give them resources on people who can help advocate for that too. So I haven't necessarily gotten pushback. I just feel like sometimes it can be a process and sometimes it can take a little bit to get those supports in place because they want to provide the least restrictive environment for those kids and they want them to be as independent as possible. So it can take time, but yeah. Yeah. Mhm.
Yeah, I haven't either had much pushback. I agree with Kiah, though, it's a process. A lot of times by the time we get involved, the school's been through it, and caregivers are, so they're both kind of like, what can we do? Well, what can we do? But that's where using that team approach to be like, well, here's what I'm recommending, but how is that going to look within this kiddo's school day? What's feasible for the school that's still going to reach this kiddo's needs, and help them out.
Over here.
So I have an 11-year-old that has this issue. He's a foster child. We got him in August, but he's been pooping his pants for a while. And what I found out, because I was going high and low trying to find a solution. So we got a doctor to diagnose him with encopresis. So basically you can't control your bowels. So Medicaid is paying for adult diapers for him. So that's a good thing if you guys need a pointer for that. And then not only that, what does help is a lot of times too, he poops when he gets excited, he poops when he gets nervous, it just comes out. So a good thing is to Miralax is a good thing for him because you can't OD on Miralax, and it's very good for the bowels. It actually brings water into the stool to help you loosen it and pass it. So if he gains control like that, it helps him. And then constant reminders, as soon as you get up, go poop. As soon as you get done eating, try to go poop. Before we leave, go poop. You have to remind him all the time. So that's been helping, but he still poops in his pants. He still poops at school. He's a little embarrassed to share that he poops and he doesn't know why. And it's easy too. You can read them a book. There's even a book out there about it, about having leaks all the time, and telling them that it's okay to tell people, and this is why I can't say it's because I'm embarrassed. And it's for both adults and children. It helps you understand them and then understand themselves. So
Share that book in the Facebook group.
Oh, yeah, that would be awesome. Well, and I think too, you touched on that, knowledge is power, right? And knowledge is power for the kids, knowledge is power for you as parents, and foster parents. So I think just helping them understand and using that scientific language with them is going to help them advocate for themselves. It's going to help them better understand their body. So it's just that knowledge is so important.
Okay, I have a question about bedwetting. So do you ever see kids just kind of grow out of the bedwetting? Because my kid, he'll be 11 next month, and it's still the bedwetting is pretty significant still. Is there sometimes we'll just stop, or is there things that we should be doing? We try to cut water off, but then I feel bad because he says he's thirsty. I'm like, just get some water then, So it's I don't know. I just have a hard time with it. We just don't really make a big deal. Okay, we clean it up or whatever, but he is almost 11. So I'm like, okay, at some point, is there a solution for that?
Oh, yeah.
Yeah. So if they've been through a lot, you should educate yourself on trauma responses, because it could be even just your facial expressions that you may not be aware of, because children are very observant, and it could be like they said, their environment, it's going to help them a lot more. If you're talking to them when they're wetting the bed, get down on your knees and talk to them. And if they're scared at night, you might want to try a nightlight, or those sticky stars. I put that in the boys' room and they don't wet the bed.
So, we really don't make any deal of it. We just say, I don't really say anything really. I just clean up the sheets and don't say anything about it. We don't really talk about it at all, unless I'm like, hey, notice that maybe you wear your wet clothes. I'll go wash them. But does it? I guess my question is, can they just grow out of doing that?
So typically we do see they kind of grow out of it, but usually it's around that 5 to 6 age, to age 7. At his age, though, I would look into kind of as she was mentioning, is there trauma, change in routine? Is there other, nutrition factors? Is there other medication or medical things going on too? And also there is a genetic component. So even if like, it doesn't always have to be a parent, but like if an uncle was a nighttime wetter, and up into like those teenage years, sometimes that can impact as well.
But I also think too, it's important, like follow your gut too. Like ask the questions that you want to ask at the doctor. You feel free to give us a call. Like I think that's it's okay to ask more questions to learn more, right? So I would say always follow your gut too. If you feel like there's something you want to know more, you think there's something else, ask the questions too.
I'll share that personally, I wet the bed until the 3rd grade. And it was an anatomical thing for me that they had to correct in order for that to stop happening for me as a child. And as soon as they dilated my urethra, it was over for me. So. Yeah.
And that age is hard too, because I feel like that's at the age where they want to start going to sleepovers, and that can be an emotional factor as well. So it's a good thing to look into and see.
My question is kind of back to the trauma and maybe the motivation or stubbornness you see in kids. I feel like I've had a lot of kids who understand this is one area they can control, and so they do control it. And it's less of a, I have all of these other things going on and I am choosing to not poop during the day, like, a toddler that will let loose at night when they're finally relaxed and sleeping and you wake up to the bomb. Or just, I don't know. I feel like I've had a lot of stubborn kiddos, or my frequent pooper who was having so much, I put her in a diaper then, an adult diaper during the day. And then she started peeing because, well, I have a diaper on. So how do you address some of those things where it's less of like, you're getting plenty of water. I mean, or you're doing this, but now this is more of or do you work with mental health therapy or?
So kids with trauma, when they come in and they have bowel and bladder concerns, my number one recommendation is, hey, let's also get mental health on board, especially one that's trained in trauma. Getting them on board is essential. We can work on our side of things, but there's that trauma piece that mental health is a big team player for us. I would also try to, because right, like you said, this is something they can control. And so trying to make it like, yep, you can control this, but depending on the age of the kiddo, I mean, you wouldn't do this with like necessarily an 11-year-old, but like depending on the age of the kiddo, okay, are we gonna hop like a bunny or hop like a frog to the bathroom to do our potty sit? Or if they're doing a potty sit after dinner, okay, are we going to read this book or are we going to blow bubbles? Kind of giving them that control, but still helping address some of those concerns. But mental health is a big one with kiddos who have experienced trauma.
And I feel like they can kind of help figure out like, what is the cause of this? Like, why do they need to have this control? And that's where mental health can really help with that too. And then finding things that motivate them. So using that positive reinforcement, whether it be a chart, or sometimes I'll have kids even like say like, okay, and what are we going to do that's extra fun in OT when you have 3 dry days next week? And then we'll talk about it, just to have that external person to kind of help with that. But yeah, I feel like even just at home, just incorporating some of finding what motivates them and what empowers them to be more independent with that as well. And then education on, if you do hold it, this is what could happen. This is going to cause pain. It's going to make it harder. It could cause an infection. I think that education is important too for those older kids for sure.
So I was just thinking, like, when I had my 3 littles and we were potty training like 2 at a time, like I was very aware of their bowel movements. Like, okay, they pooped yesterday and they haven't pooped yet today. So I wonder if they're getting I saw what was in the toilet and I paid attention to everything. But I was thinking, as you were talking, I was like, now they're all potty trained and independent. I'm like, I really don't know what's going on. Like we were just saying, I think maybe the middle one is probably constipated a lot. But I mean, I don't, other than when they forget to flush the toilet, which is fairly often, but they don't say which one it was. So I'm like, I don't know whose poop that was anyway. It was not helpful. So, but I was just wondering, are there questions where you can make these kids be more aware? Like, are there questions I could be asking them? It sounds weird to ask about, this and that, but they're boys, so they probably want to talk about poop anyway. But I mean, just to ask questions like, did you poop today? Or, something where they're more aware of maybe what they're going, other than me following them to the bathroom every time. I'm not sure how to really know what's going on with their bodies.
Yeah. So I think going back to that visual that we had, asking them what it looks like, and it, like you said, they're boys, kids, they like to talk about poop and it's funny. And so even like asking them in a funny way, like, okay, so did your poop look like a corn cob or a bunch of grapes? Like, and just kind of giving them like, oh, they can laugh and tell you exactly. So I think that's a good way to tell too. And I mean, if they're complaining of like discomfort or pain in their tummy, that's another way to tell that if they're constipated. But as far as just like kind of monitoring when they're going, how often they're going, I think it's okay to do that too. And then even just after they go to the bathroom, did you poop or pee? Like just a quick question. It's okay to ask too, just to check in on them. But
You can always too, like there's a lot of books out there that talk about kind of the anatomy and like what happens. Kind of as excuse me, as I referenced before, what happens the second food comes in and the process and everything. And then it works through the digestive system. And then that would be a good talking point too of, hey, this is what happens if we're not pooping every day, or and kind of educating them through that. So then they're kind of like, oh yeah, like, and in the back of their mind, they're learning about it too. Yeah. I think Usborne Paper Pie, they have some good ones out there on that.
yeah, we have one of their books and it has like flaps so they can look like, oh, the food goes in here and then it gets mushed up and then it goes down here. It's a really fun way to learn.
Or
about it,
Amazon, I'm
too.
sure if you just type in, books about pooping or the body, like the digestive system, kid friendly,
Any other questions or it could be about.
The book was called Beating Sneaky Poop. Okay. No, poop. Okay. Thank you. And that books, I'm glad you brought that up. Books are a great way for kids to learn. And it makes it fun for them versus an adult just like talking at them about it. Yeah. And it also gives them that feeling too that, hey, there's a book written about this. Like other kids go through this. So I think that makes them feel better too.
Yeah.
Yeah.
Sure. Okay. Well, thank you guys so much for having us. We can hang out a little bit too if you have any questions for us that you didn't feel comfortable asking as well. But yeah, we were really happy to be here. We love talking about this topic. So thank you so much for having us.
Yeah. If you guys have any questions in the future though, just give Kids in Motion a call. Even if you don't remember our names, just ask front desk, hey, can I talk to someone trained in bowel and bladder? And they'll be able to get you one of us or another therapist who's trained in it. So thank you.
Thank you.